So thank you all for coming, and thanks for inviting me to present today. I'm looking forward to sharing some of our experience so far with piloting group antenatal care as an alternative to traditional individual prenatal care in Senegal. And this project's a collaboration between the Sick Kids Center for Global Child Health, where I work, the Institut de Population, Développement et Santé de la Reproduction in Dakar, at the Université Cheikh Anta Diop in Dakar, Plan International in Canada and Senegal, and the Division of Reproductive and Child Health of the Ministère de la Santé de l'Action Sociale. So still today in 2018, an estimated 830 women die from preventable causes related to pregnancy and childbirth every day around the world. Almost all of these deaths occur in low-resource settings, primarily in developing countries, and a majority of both maternal and perinatal deaths are preventable with good quality care during pregnancy and childbirth. So, antenatal care, or care that women receive during pregnancy, so-called prenatal care, can play a central role in ensuring positive outcomes for pregnant women and their babies, can contribute to reducing maternal and perinatal mortality directly through screening and treating pregnancy-related complications, and also indirectly through identifying high-risk pregnancies that may require closer monitoring or referral to higher levels of care. And importantly, ANC also provides an opportunity to communicate and provide support to women and families regarding appropriate care-seeking practices and health behaviors during pregnancy, childbirth, and into the postnatal period. So in terms of global coverage of antenatal care, most women receive at least one ANC visit during pregnancy, and around 60% of women receive what has been the recommended 4 visits during pregnancy. And for the region of sub-Saharan Africa, just around 50% of women receive 4 or more antenatal care visits. But so not only is there still a ways to go to achieve universal coverage of antenatal care, it's really clear that just measuring the number of visits is not equivalent to ensuring high quality care, high coverage of comprehensive and high quality care. That's going to translate into better outcomes. And this paper that was published in BMJ Global Health in 2016, it really highlights this point. So if you look at the column for Zambia, you can see that nearly all women, so almost 99%, receive some antenatal care during pregnancy. But if you look down at the percent who receive the recommended 4 visits and also start in the first trimester, which is important, it's only around 20%. And then below that, you can see that of that 20% who receive 4 visits and start in the first trimester, only 37% received these 6 components that were measured, including getting blood pressure measured, protection from tetanus, and receiving information on potential complications. So while Zambia could claim almost universal coverage of antenatal care, in reality, very few women are actually receiving comprehensive, high-quality care. And it's not unique to Zambia. It's a consistent pattern in many low-income country settings. So with growing consensus that antenatal care as it's currently being delivered in many settings results in a lot of missed opportunities to prevent maternal and perinatal morbidity and mortality, the WHO in late 2016 reviewed the existing ANC guidelines and released a new set of guidelines for antenatal care. And these guidelines are recommending a major shift from the focused ANC model, which has been in the 4-visit model, which has been in place sort of since the early 2000s, to a more holistic, woman-centered model with more frequent contacts. So in addition to effective clinical practices, the new guidelines place equal importance on providing effective communication about biomedical, behavioral, sociocultural issues, and also effective support, including social support, emotional support, and psychological support. So, one potentially promising alternative model of care that might help achieve the goals of improving utilization and quality of ANC services is group antenatal care. So it's a model where 8 to 12 pregnant women of approximately the same gestational age meet with, usually it's 2 co-facilitators, to receive antenatal care during the course of pregnancy. And just wanted to note that group ANC is replacing traditional antenatal care, so it's not like prenatal classes in addition to traditional ANC. It's replacing the model. So the group visits last around 2 hours, and there's a strong emphasis on education, counseling, psychosocial support, and engaging women more fully in their care, in their own assessments. And providers are trained to move from sort of instructor mode of just providing information, as is often done in health education sessions, to learning to like engage active participation and facilitate discussions that are really led by women in the group. And the most widely known model of group antenatal care is called Centering Pregnancy, and it was developed in the mid-1990s by an American midwife with the aim of improving social support among pregnant women and empowering them to choose health-promoting behaviors. And this centering pregnancy model has been adapted and implemented in many different countries, in Canada, in many countries in Europe, and other countries around the world. So, Group ANC has 3 key elements. The first is clinical assessment, which includes both self-assessments, where women learn to monitor their weight and blood pressure, and they also receive short individual consultations with a provider, usually a midwife. The second is peer-to-peer learning that's facilitated by ANC providers, and it's engaging women in activities where they're reflecting on their own resources and ideas, values, to develop plans and actions for a healthy pregnancy and birth. And then the third is peer support. So women getting to know each other in the group, building group solidarity, and just promoting building relationships and shared problem solving. So, as I mentioned, Group ANC has been around for decades, so there has been a lot of research, almost all of which is from high-income country settings. So a consistent finding is really high acceptability and satisfaction of the model of care among pregnant women and providers. So pretty much across all studies, women and providers really like this model of care. But when it comes to sort of the impact of Group ANC on health outcomes, there are a lot of claims made about positive effects on many different outcomes, but in reality, there are few rigorous studies and especially few adequately powered studies. So there was a 2015 Cochrane review of randomized controlled trials comparing group A and C to individual A and C, and they concluded that the available evidence suggested that group antenatal care is positively viewed by women, and it's associated with no adverse outcomes for them or their babies, but limited because of the number of studies was small and the number of women was small. There is, however, some evidence from randomized controlled trials suggesting the model may be particularly beneficial for some vulnerable populations. So there were studies of pregnant adolescents and socioeconomically disadvantaged women showing reduced rates of small for gestational age and preterm birth. But overall, more high-quality research is needed, and especially in low-resource settings. And in fact, in the new WHO ANC guidelines that I mentioned, under recommendations for health system interventions to improve utilization and quality of care, the World Health Organization has endorsed further research on the feasibility and effectiveness of group antenatal care. Okay, so, and currently there are several ongoing studies of group antenatal care around the world, and there is this global group antenatal care collaborative that was formed as a sharing and learning resource for projects looking at the effectiveness and the feasibility of group A and C. And there are several feasibility studies looking at how the group A and C model might be adapted for different contexts to account for different health systems, different economic and socio-cultural characteristics of different settings. There are also 2 large cluster randomized trials looking at the effectiveness of group A and C compared to traditional A and C on maternal health and birth outcomes. And those 2 studies, one is in Kenya and Nigeria, and the other is in Rwanda. And they're still ongoing. And so the study that I'm going to discuss today is a feasibility study in Senegal. Okay, so in terms of the objectives of the research, the first is to investigate the feasibility of group A and C in Senegal. So to look at the acceptability among women, adolescents, families, and health providers. To understand the contextual factors, so factors related to the health system or sociocultural factors that influence adaptation of the group A and C model in Senegal, and to understand what the essential resources needed to implement group A and C are. So personnel, infrastructure, those types of things. And the second objective is to collect necessary information to plan a larger scale implementation trial, if that would be warranted by the results of the feasibility study. So we're piloting a data collection strategy and tools that could be used in a larger study, and collecting data to estimate the prevalence of key outcomes that could then be used for sample size calculations. So it's sort of a hybrid design. It's a feasibility study and then a pilot cluster randomized trial. Okay. So there were several factors that suggested that Senegal might be a good context in which to explore the feasibility of group A and C. So maternal and neonatal morbidity and mortality remain elevated, and improving reproductive, maternal and newborn health is a priority of the government. Almost all women receive some A and C from a skilled provider, So if implemented in Senegal, Group A and C would have the potential to reach nearly all pregnant women. And there also tends to be limited provision of education and counseling during antenatal care. So according to a large national survey, less than 20% of women had discussed their plan for delivery or were informed about family planning or exclusive breastfeeding during antenatal care. And lastly, there's also a strong tradition and experience in Senegal with community-based sort of group strategies, women's groups. There's been some community-based pregnancy groups, École des Maris, husbands' schools, and we thought that sort of this experience might help bolster acceptance of Group A and C. So in terms of an overview of the study, it was designed as around a 2-year project. The first phase was a preparatory phase where the main task was to adapt a Group A and C model and curriculum for Senegal. We then trained trainers who would then provide the training for the health providers for the study. And we also conducted a health post assessment to screen health posts for eligibility to participate in the study. Phase 2 is the implementation of the study, so including training providers in Group A and C facilitation, recruiting women into the study, and collecting data throughout this phase. So currently we're wrapping up phase 2. There's about 6 weeks left of data collection. And then the last phase will be to revise the model and the curriculum based on our experience and feedback from providers and research staff and others, and then preparing the results and holding some workshops and disseminating the findings. So the Group A and C model and curriculum that we used is based on one that was developed by JPIGO, which is an organization affiliated with Johns Hopkins University, and it's currently being used in a study in Nigeria and Kenya. So the major adaptation was to align the model with Senegal's A and C protocols, so respecting the content of antenatal care and also the number of visits. We considered the types of providers who would be trained to facilitate Group A and C. And so in addition to nurses and midwives, we trained matrons, who are community midwives that work under the supervision of midwives to provide maternity services in health posts. And finally, one of the collaborating partners on this project, so Plan Senegal, had been working to engage men in reproductive and maternal health. So we saw an opportunity to integrate some of their experience into the Group A and C model, and I'll talk about that. Okay, so this is just comparing the traditional 4-visit A and C model with the Group A and C model that was adapted. And it's just to show that all of the clinical content remains the same between the two models. For group care, women enroll in Group A and C at the first A and C visit, which is always an individual visit. The one major deviation with the group model is the addition of this a supplemental visit after the third A and C visit, which is a visit where no clinical care is provided and partners or other support persons are encouraged to attend. And the other thing to note is that each of the Group A and C visits has a specific theme. So Visit 1 introduces Group A and C, discusses preventing problems during pregnancy. Visit 2 is about danger signs and appropriate care seeking. So the third visit, the partner visit, is focused on birth preparations and family planning. And the last visit is what to expect during labor, as well as maternal and newborn complications after delivery. Okay, so what happens during a Group A and C session? Each of the sessions lasts around 2 hours and has the same basic framework. So it opens with some sort of a ritual that women develop together in the group. So many of the groups have a song that they sing at the beginning of each session. And the idea is just to start with something that's light and fun and brings everyone together and makes everyone feel part of the group. Then there's an evaluation component, which includes some simultaneous activities. So during this time, each of the women meets briefly with the midwife for a short consultation for any clinical exam or any private issues. And then at the same time, the other women are taking their own weight and their own blood pressure. So we have these small automatic blood pressure devices that women are using. And then we have these self-evaluation cards, which are laminated. So each woman has one of these cards, and this is showing one side of the card. So to write down the weight and blood pressure, and then also to mark any danger signs that she's experienced during pregnancy or since the last visit. Maybe. So after the evaluation component, women and providers regroup in a circle and begin participatory activities and discussion around the day's topic. The facilitator manual includes some proposed activities for each session, and there's a set of picture cards also that are used to sort of facilitate the discussion. And the pictures are all from the mother-baby booklet that's used in Senegal that all women have and keep with them. And then at the end, there's just a short time for women just to socialize, and we provide some small snack and tea. And that's it. All right. So we decided to pilot Group A and C in the district of Kaolack, which is about 250 kilometers southeast of Dakar, the capital. And we thought Kaolack was a good choice of location to assess feasibility. So it's a district with a major urban center, also diverse rural settings, has sort of a socioeconomic and ethnic diversity that resembles the national population, and also coverage of reproductive and maternal health services similar to the national population, quite high coverage in general. So we implemented Group A and C in health posts, and these are facilities headed by nurses that provide most of the essential health services to the population, and that includes antenatal care. So we did have a few eligibility criteria for health posts to participate in the study. So they had to have, sort of on average, a minimum of 15 first A and C consultations per month. That was just to ensure that there were enough women to be able to form groups. Also a minimum of 2 A and C providers, so 2 providers like midwife and a nurse generally, and 1 matron, and adequate space to hold Group A and C meetings. So some sort of a space where, you know, up to 12 to 15 women could like group in a circle, basically. So we identified 18 health posts, possible health posts in the district, and selected randomly 6 of them for intervention, and 2 would be control sites, and we allotted an equal proportion of urban and rural areas. So once we had identified the facilities that would participate, we held 2 3-day Group A and C facilitator trainings. So the midwife, the head nurse, and 1 or 2 matrons per health post were trained. And the training focused on learning and practicing facilitation skills primarily, and also becoming familiar with the facilitator guide and the content in the guide. So recruitment of women into this study began just after the training, and women were enrolled for a period of 4 months. The initial eligibility screening was done by providers at the first A&C visit, and then follow-up was done by research assistants, and the research assistants also administered a baseline survey. So women were eligible to participate as long as they were 15 years of age or older. They were at a gestational age of 5 or less months, and they were planning to continue A&C at the facility, and of course they provided consent to participate. So a total of 331 women are participating in the study, 245 in group antenatal care, and 86 from the 2 control facilities. And so of those 245 women, they are grouped into 25 groups. And so there are, let's see, 4 visits per group, so that's 100 sessions that are being held. And the group sizes ranged from 4 to 16. So we use different data collection approaches, both qualitative and quantitative. So surveys were conducted at baseline, so at enrollment, in both the group A and C and the control arm. And then also survey was conducted 6 to 8 weeks after delivery. We carried out focus groups at the end of the last visit, so the 4th A and C visit. And then we're conducting also semi-structured interviews with pregnant adolescents who participated in group antenatal care, because from the beginning there was a discussion about how this would work, having adolescents and adult women in the same groups, and whether adolescents would really feel comfortable in this setting and in sort of participating in a group. So we did some additional interviews with adolescents. We did interviews with male partners of women in Group A and C, both those who participated in the partner visit and some who chose not to participate or who didn't participate. And then we have surveys and interviews also with all the providers to understand their experiences with Group A and C, and what they liked about the model, what worked and what didn't work, and sort of what the challenges were for them. All right, so in terms of feasibility outcomes, we're measuring, of course, we want to know about acceptability of the model. So among providers, adolescents, pregnant women. Also coverage of Group A and C, so what proportion of women attended all of the visits. Fidelity to the Group A and C model, and this was determined through supervisory visits of the research staff, so observation of a group session and filling out sort of a checklist that covered the key essential components of Group A and C. We're conducting a cost analysis also to estimate the cost to implement Group A and C, as well as the time costs for providers and women between sort of Group A and C and individual A and C. And then we're planning to interview providers 6 months after the end of the study, just to see whether they continued to offer Group A and C and to understand their reasons for deciding to continue or not. And so all these factors I think are important to support decision making if there is interest in continuing further research or implementation of group antenatal care. Okay, so I don't have a lot of results to show yet, but one thing that's pretty clear is that, like other Group A and C studies, our findings show high levels of satisfaction with the group care. So women who participated were asked, if you became pregnant again, would you prefer to receive group antenatal care or individual care, and why? And 97% said they would prefer to receive group antenatal care. And in terms of the reasons for preferring group antenatal care, the main themes were related to learning a lot about pregnancy-related issues and building relationships with providers and other pregnant women in the groups. So I mentioned that we had a particular interest in the experience of adolescents in Group A and C. And so far it looks like a majority of both adolescents and adult women said that they were comfortable speaking openly and sharing ideas within the group. So from the interviews with adolescents, some did express feeling shy within the group and said that they would feel more comfortable with peers their own age. But many did feel more comfortable over time within the group and also learned a lot from older women in the group and appreciated hearing about their experiences and receiving their guidance as well. And I think almost all of the adolescents really appreciated what they learned. For many of them, it was their first pregnancy, and they learned a lot about how to prepare for delivery and keep themselves and their babies healthy. So I mentioned about the supplementary group visit where male partners were invited to attend, and this session was facilitated by the midwife, and also we trained some male facilitators. So it was co-facilitated by a midwife and a male facilitator. So in general, attendance of male partners was pretty low, around 1 to 2 partners per ANC session, and often a few women would also bring their mothers or their mother-in-laws or other support people, which was also encouraged. Men who participated tended to be younger and in monogamous unions, and not very surprisingly, most didn't participate just because they weren't available. They were working and or traveling. Some weren't informed about Group A and C by their partner, and some were just not interested or other reasons. So just to wrap up, I'll leave you with, I don't know, a few interesting observations or lessons learned through the implementation of the study. So there was a pretty major strike of healthcare workers for about 3 months during the study. All non-emergency services stopped Tuesday to Thursday for about 3 months. So any Group A and C visits that were scheduled on those days had to be rescheduled. And it was actually really impressive to see the level of motivation of the providers because all of the sessions got rescheduled and many of them were held on Saturdays. So another thing was that there seemed to be a systematic underestimation of gestational age dating, so that a third or maybe even more than a third of women actually delivered before the last A&C visit. So many actually ended up bringing their newborns to the last visit, which is nice. And actually the topic for that session was about newborn care and care after delivery. And lastly, we were really lucky for this study to have, I don't know, like a champion of Group A and C in the District Sexual and Reproductive Health Coordinator in Cowlack. She attended all of the trainings. She participated in most of the research meetings. She did a lot of supervision in the district. And she's already keen to expand Group A and C to other facilities in Cowlack. So we'll see what the rest of the results show. So I wanted to acknowledge, of course, all of my colleagues in Senegal, especially in Cowlack, and at Sick Kids as well. And this was funded by Global Affairs Canada. So thanks. We'll see.